Good evening. Good evening and welcome. Thank you for coming to what is the final Visionary Conversation event of the 2013-2014 academic year. My name is David Barnard. I'm the President and Vice Chancellor of the University of Manitoba and your host for this evening. We're here tonight in Treaty 1 territory on the traditional land of the Anishinaabe peoples and the homeland of the Métis Nation. The university and the forks of the city sit at the crossroads of the Anishinaabe, Métis, Cree, Dakota, and Oji-Cree nations. Those who joined us in previous sessions this year know that we have a partner, CBC Information Radio, so please join me in welcoming Terry McLeod, who's sitting over here. Terry's host of CBC Information Radio's weekend show. He'll be monitoring social media, and we'll try to take a question or two from him later on. Our topic tonight is the evolution of the rights culture. Do we have the right to die? Doesn't seem to be inalienable, I think, the right to die. Canadians are currently debating what's commonly called the right to die and euthanasia. The Supreme Court has this matter potentially in front of it. The discussion's often polarizing. We're fortunate tonight to be joined by alumni, friends of this community, and our distinguished scholars who will explore various aspects of this argument, of this topic this evening. And of course, many of you will note a change in our panelists this evening. Unfortunately, Professor Schaefer was unexpectedly unable to join us because of illness. I'd like to thank our distinguished alumnus, Dr. Paul Hentelef, for very graciously stepping in on short notice. And as always, those of you in the audience will play a substantial role in the evening. The format will be this. Each of the three panelists will speak for about 5 minutes on this theme, and after they have completed their remarks, I'll come back and ask for questions and comments from the floor. There are a couple of my colleagues who will be circulating with wireless microphones, and I would ask you to wait until they get to you to pose your question, because we are recording the material and you need to be mic'd. We want to get to as many members of the audience as possible, so I would ask you to try and be brief in your questions and comments. If you're so inclined, you can follow our conversation on Twitter. The hashtag is #UMVisionary. We'll wind up the discussion just before 8:30. So now it's my pleasure to introduce our first speaker tonight, Dr. Paul Hentelef. Dr. Hentelef is considered by many to be the father of palliative care in Manitoba, and indeed was pivotal in leading the way for the establishment of hospice and palliative care programs across Canada. He grew up in Stonewall, graduated from the Faculty of Medicine at this university in 1956. Initially, he worked in a general family practice, but after 12 years, he took a job as the Assistant Executive Director of Manitoba Health Services Commission. In that role, he helped design Manitoba's personal care home program. Dr. Hentelef then returned to clinical practice, this time at St. Boniface Hospital. There, he quickly assumed the role of Medical Director of the Terminal Care Unit. The Terminal Care Unit, which opened in November of 1974, was soon renamed Palliative Care Unit, following the example of Royal Victoria Hospital in Montreal. Dr. Hentelef retired in 1991. So this is the definition of retirement. That same year, he became the founding president of the Canadian Palliative Care Association and remained at the helm for its first 4 years. In 2013, he retired from that board, the Board of Hospice Palliative Care Manitoba, after more than 20 years as a board or committee member. Please join me in welcoming Dr. Paul Hentelef.
Am I supposed to stand up?
As you wish. You can stand there, sit, stand here, whatever you like.
If I get restless, I'll stand up. A couple of opening remarks. I'm dismayed to have what I thought was my most witty observation stolen from me, namely the challenge of the term right to die. I've commented many times that if there was ever an inalienable right, that's it. All the others seem to be alienable. The other thing I'd like to say by way of an opening remark, in case anybody here has known me for a long time, it's approximately 20 years ago I spoke on behalf of the Canadian Palliative Care Association to the first Senate committee looking into the question of assisted suicide. I believe that was the term at that time. It always changes. And the position of the association, which I delivered, was very strongly negative about assisted suicide. My personal position was that morally I wasn't against assisted suicide. It was a question of what kind of policy was suitable in Canada at that time. And I believed then that until palliative care, or hospice palliative care, was well established in the country, it would be much too easy for physicians to learn how to provide a lethal dose of something, one way or another, to patients on request, and much more difficult to learn what I had spent some 15 years cultivating and perpetually learning, namely the hospice palliative care approach to looking after people who were terminally ill. The associations have since dropped their absolute negative position against assisted suicide, saying that that has nothing to do with what hospice and palliative care offer. Now, I better talk about the position in favor of assisted suicide. That's what I came here to do. And I said that even then, I wasn't against it morally. Perhaps the most transformative thing that happened for me was in the course of looking after patients in the palliative care service. One of the patients told me about his period in military service where, at the request of a seriously wounded comrade, he was asked to put the man out of his misery, and told me that he did. He did that without pride, but he did it with a sense of duty accomplished. It so happened at that time that there was a terrible air accident in the Arctic in Canada. A plane was down in circumstances where it was really impossible to get to it for a matter of a few days. And I could imagine then in civilian life, circumstances in which a severely injured person with no prospect of recovery might say, "Put me out of my misery." And I would have to be as sympathetic in that position as in the traditional honored military approach of responding to a comrade who says, "Put me out of my misery." I don't think it's a pleasant task to undertake, and I think it was undertaken in the example I've given out of a sense of duty. Then beyond that, gradually coming to understand that as much satisfaction and reward as I was getting out of hospice and palliative care service, that in fact a small portion of people don't respond to the very best of efforts that can be given to them by hospice and palliative care services, and will occasionally say, "Couldn't you do something to end this for me?" I've also witnessed a personal friend who was in the palliative care service, was reasonably comfortable, but woke up each day not knowing why is he still alive. Couldn't it end? Because each day was a black vacuum for him. I don't think he was what you would call clinically depressed. His life was totally empty. He saw his life as having been very full and now complete. He had looked after all his personal arrangements, that is, his affairs were in order. He was ready to die, but couldn't. Just one more closing remark. I don't know how much time I've used up, but it must be getting close because we're limited. a large part of the Canadian population, in fact a majority, favors assisted suicide. And I think that, from what I understand about human beings, that comes out of an anxiety about several things related to how one might die. Dying in agony is a quotation marks kind of statement that people know and don't appreciate that idea. To a very large extent, hospice and palliative care can relieve that so that there isn't agony. But it doesn't always work. That's one thing that people are afraid of. What a person sees as their personal sense of their own worth and dignity often includes a sense of independence, and the state of deteriorated health to the degree of being totally dependent can be repugnant. I realize that there will be people who might be induced to say that when pressured by other people, but it can certainly come out of an internal self-evaluation that life isn't worth living in this state of dependency in which they find themselves. That would go on to include anticipation of severe dementia, I think. Although we're talking about assisted suicide, I haven't seen anything that would allow an advance directive to be invoked when a person is too demented to any longer have a free request for that service. Closing. My understanding is that where people are provided with the means of suiciding, it can often, and probably in a majority, serve as a reassurance of an availability not to die a horrible death the way they feared, but they don't necessarily use it. It would seem to me that the majority of people who have, from what I understand, the majority of people who have that means available to them don't take it. I guess there's one other closing remark I have to make, and that has to do with the term physician assisted is typically attached to the proposal. And in a way, as a physician, I wonder, well, why is that really necessary, that it be a physician who carry out this task? Well, in fact, the means of bringing one's life to an end, apart from a knife or a gun or a jump, the means are only available through physicians by prescription. Some people say, well, why not a pharmacist? Pharmacists can dispense, but they can't write their own prescriptions. So I don't see, without an even bigger change in our legal structure, how people could be assisted in their dying when they request it, apart from a physician having a role in it.
Thank you. Thanks, Paul. Our second speaker tonight is Dr. Mary Sharif, who is an associate professor in the Faculty of Law at the University of Manitoba and an alumna of this university. She currently teaches bioethics and law, as well as contract law in the JD program and legal research and theory in the LLM program. She's a research affiliate of the Center on Aging and the Desautels Center for Private Enterprise in the Law, both here at the University of Manitoba. Her principal area of research is bioethics and law, and includes research related to death, aging, palliative care, global bioethics, the environment, and animals. Currently, she's examining end-of-life and assisted death in a variety of legal contexts, including comparative law, distinctions between dignity and autonomy, the slippery slope, access to palliative care, international human rights obligations, and mediation. Her works on assisted death have been published in the McGill Journal of Law and Health, Health Law in Canada, and the Canadian Medical Association Journal. She's co-author of the 4th edition of Canadian Medical Law, an introduction for physicians, nurses, and other healthcare professionals. Please join me in welcoming Professor Mary Sharif. Thank you.
Thanks for having me here this evening. I'm standing because I need to see I've got a little slide, one slide, and I have 5 minutes to talk. And I'm going to try and cover everything on there except for the very top of that. In trying to be as efficient as possible, I've decided to try to just address how I try to formulate what is going on in terms of the legal process that's taking place in terms of defining a right to die. So I've got a few points to cover here. So basically we have a conflict where you have individuals who have suffering that they do not feel can be relieved, and there's no reasonable solution to take care of their suffering. And so they want to be able to either end their life or be able to have the choice to determine the timing of the death event for themselves. That is in conflict with the overall protection of life, or the obligation to protect life and respect life. So we have this very complex social, moral conflict. And it requires a satisfactory response. So we have to actually address the issue. We have to come up with a response because we have this very significant conflict. So how do we respond? Well, in Canada right now, we have the situation where we have two legal processes going on. We have the judicial system looking at the issue, meaning the courts are looking at the issue in the Carter case, which is a case that comes out of British Columbia, but is going now to the Supreme Court. And we also have the legislative process going on, where we have legislation floating around in Quebec with respect to assisted death, as well as a bill having been introduced into Parliament by Stephen Fletcher. So we've got two processes happening. Now these processes are very different. They have different stakeholders, they have different participants, and the scoping of the issue is quite distinct because of the nature of these processes. But they have a couple of things in common. First of all, both are trying to figure out, okay, what are the possible justifications to allow assisted death? And they're trying to identify those, as well as if we do allow it, and how do we justify it? What will be the consequences? What are the possible externalities of that decision if we go forward with some form of assisted death scheme in Canada? Now, seeking out those possible justifications for assisted death involves considering varied rights and duties. Now, some of the rights being tied to assisted death or legalization of assisted death are the constitutional rights. The principal ones that are being invoked are the right to liberty and the right to security. So these are the arguments that would be made saying, I have the right not to be interfered with when I'm making decisions of a very personal nature. I also have a right to choose and to make decisions around my bodily integrity. Now there are other constitutional protections that are also being invoked. This would be a right to equality as well as a right to life, but it's really not an issue about a right to equality. But there's legal arguments around the right to equality that are very technical, but the essence of the conflict doesn't actually involve an issue of equality, I would argue. In addition to the constitutional sort of framework around advancing assisted death right, or a right to die, we also have to think about it in the medical context because there are additional patient rights that come into play, given that this is most often a medical situation. So we have rights like informed consent and also right to refuse treatment. These are kind of very important pieces because we see the evolution of the right to refuse treatment as being sort of the genesis for this concept of right to die. And we see this playing a role in the American legislation. Now, there's a saying in law that a right isn't really a right unless there's actually duty or an obligation that can give effect to that right. So we also have to consider these duties. And we can think about duties from the perspective of the state, or duties from the perspective of medical physicians, or even duties from the perspective of individuals and family members towards each other. So without, delineating between the three, we could see that there's a duty to protect life, there's duties to respect life, there's duties to respect autonomy, medical duties to do no harm as well, to do good, and to release suffering. There's also duties of care, right? Physicians toward their patients, and there's also obligation to do justice. So the tricky part and the tricky territory is then the matching of the rights with the duties, and it's not necessarily that easy. And I say it's tricky because the articulation of a right to die is based on freedom from interference or by the state with your personal decision making is really a negative right, right? It's a negative right. I should be free from interference. But what is happening and where the discussion is going is the transformation of that negative right, free from interference, into a quasi-positive right where you can get somebody to help you. They wouldn't be compelled to help you, but you would actually get somebody to help you. So there's some kind of transformation that's occurring there. So we're also looking at not just this concept of right to die, but we're also looking at an issue of agency. Now, the other piece of the puzzle is this consideration of externalities, and this is part of the discussion that people have a difficulty with, because one of the arguments against considering consequences is that it's too speculative, right? We hear that all the time. We don't want to speculate about the slippery slope and so on and so forth. But we have to think about it because depending on how that right is articulated, will actually carry with it different consequences. So a good example is if we advance on the right to autonomy, and we say assisted death because it's an autonomous decision, well, autonomy carries very little restriction to it. It doesn't mean that it has to be restricted to a medical circumstance, for example. What would actually anchor assisted suicide if we wanted assisted suicide for terminal illness if it's all just about autonomy? Well, nothing, and that's what we see in Switzerland. So we also have to ask that question, if we proceed, because rights are not absolute, individual rights are not absolute, we also have to think about rights of the collective. If we are to proceed, how might that decision then impact the rights of others, right? And how might it impact not only their rights, but in the potential for us to fail to carry out our duties to protect life? All decisions, and I'm borrowing this language from an academic by the name of Eugene Volokh, and he says all decisions change the political, the economic, and the psychological conditions in which future decisions are made. So we have to think about this. So the question is, how robust a conversation are we going to have about those externalities? And I would argue that we're not doing enough. We're not doing enough. In my own view, I think the Canadian debate up till now tends to focus more on the form of assisted suicide. And I say this because when we look at the court case, and we look at the legislation, what is being generated there is not an assisted suicide or physician-assisted suicide scheme for terminally ill or dying people. What we see is the Netherlands or Belgium scheme, which is principally a euthanasia scheme for people with irremediable suffering with no reasonable solution. So I think that's interesting that both the judicial system, the court system, and the legislation that's being proposed all focus on the Netherlands Belgium scheme. So I'm just going to wrap up here. I guess I would ask the question, why are we focusing on the Dutch scheme? Culturally, I don't know how much we have in common with the Dutch. We might have more in common with the Americans. So where's the conversation about the American scheme, which is really about assisted suicide only for the terminally ill? It's kind of a curious thing to think about. 2 more points. In terms of Canada, we do have precedent. We have precedent, and the precedent exists in the criminal law, where the criminal law has demonstrated a certain amount of leniency or exercise of discretion not to prosecute in certain assisted suicide and euthanasia cases. And that lack of prosecution or leniency towards prosecuting or towards not prosecuting has been used to support the argument that, well, we're doing it anyway, so we may as well get it organized and create a big regulation around it and be more transparent about what we're doing. But there's other ways to interpret that. For example, the lack of prosecution or jail time indicates some element of compassion or empathy towards the people who find themselves in very difficult situations. So I asked the question, well, can that empathy or that compassion also be captured in law? And if we look at the United Kingdom, we see very recently in the last 3 years or so that they actually passed prosecution regulations that look at compassion. And they set out criteria for determining whether or not they're going to proceed with a prosecution. And one of the factors against bringing a prosecution is specifically that. They look at the motivation of the assister to the suicide, whereby a family member who acts out of compassion will be a factor against prosecution. So we need to think about a bit outside the box, other than the Dutch scheme, I think. Finally, my last point is that if Canada decides to create a national system for assisted death, then I think, and if it's grounded on autonomy and consent, informed consent, then at minimum, I think the legal order of operations, if you will, has to make palliative care available to all Canadians. If we can't make palliative care available to all Canadians because of a resource issue, for example, then what does that actually tell us about the autonomy and consent thresholds that are being captured in a national assisted suicide scheme? That's it.
Thank you.
Thank you.
Thank you, Mary. Our final speaker is Dr. Harvey Max Chochinov, a distinguished professor of psychiatry and director of the Manitoba Palliative Care Research Unit at Cancer Care Manitoba. His seminal publications addressing psychosocial dimensions of palliation have helped define core competencies and standards for end-of-life care. Harvey holds the only Canada Research Chair in Palliative Care, and he's an alumnus of this university. His research has covered diverse areas pertaining to palliative care and dignity at the end of life. He's the author of many publications, one of which is a book with the title Dignity Therapy, Final Words for Final Days. The book outlines a psychological intervention developed by Dr. Chochinov and his research group to address the psychological, existential, and spiritual challenges that patients and their families face when a loved one is near the end of their life. Dr. Chochinov is also the co-founder and chair of the Canadian Virtual Hospice. He's a fellow of the Royal Society of Canada and a fellow of the Canadian Academy of Health Sciences. Please join me in welcoming Dr. Harvey Max Chochinov.
So thank you very much. It's good to be here and to have this opportunity. I'm going to make the assumption tonight that because the hall is full, that everyone is here because they're afraid of death, or particularly how they're going to die. And our conversation about right to die is really our entry point in a secular society about discussions regarding death. So if we're going to talk about your fear of dying, first of all, as one lone psychiatrist in a room of 300 anxious people, I'm not sure that it's going to be nearly enough for this crowd, I have to say. But if we're going to talk about death and dying, then let's imagine for a moment that this room is representative of Canadian population in terms of age, geography, socioeconomic, and cultural diversity, and talk about how we're going to die. Now, for the people in the front row, could you just raise your hand very quickly? Including you, yes, the sound people. Okay, so that represents about 10% of the people in the room. You are representative, and sorry about this, you're the people who showed up first, but you represent the people who are going to die suddenly. The good news is it's going to be over quick. It may hurt, but it's not going to hurt for long. And it's likely going to be a little bit tough on your families. Which means that for the rest of you who arrived a wee bit later and were out there getting the snacks, there's going to be some forewarning. Now, if I can have the next 3 rows, so rows starting there, and yes, Dr. Shajanya, yes, your row, good. Okay, terrific. So that's about 30%. And you represent the 30% of Canadians who currently have access to comprehensive quality palliative care. I mean, some people may say that it's only 15%, depending on which specific populations we're talking about. But let's sort of go with the 30% for a moment and say, how will you die? Well, I can tell you that with access to comprehensive palliative care, you're not going to die in pain. 90% of you will have good pain control without sacrificing conscious awareness, and the rest of you, there may be some degree of sedation to achieve pain control. Your symptoms are going to be well controlled, or at least you'll have a team of people who are going to be working as hard as they can to make sure you are comfortable most of the time. You're going to have access to psychological and spiritual supports, although the spiritual and existential suffering is something that we probably struggle with more so than our ability to actually achieve comfort in terms of physical issues. There's a pretty good likelihood that you're going to die in a place of your choosing. Most of you would choose to die, if you could, in your home setting, and most palliative care programs have a rate of home death of somewhere of the magnitude of about 70 to 80%. If you're lucky enough to live in a city like ours, you're going to have access to expert services that can see you in your home, so your palliative care needs can be attended to there. And you also will have the safety net of likely being able to enter into a palliative care facility if your family is having a hard time coping, or if you no longer wish to die at home, or the circumstances of your dying require that kind of inpatient expertise. So everybody who hasn't raised their hand, if you can do so now. All right, so let's take a look around and see what proportion of the room has raised their hand. So you represent the 70% of people, serves you right for coming a wee bit late. You represent the proportion of individuals in Canada who will not have access to palliative end-of-life care. What will your death look like? Well, your pain may or may not be well controlled, and most doctors aren't terribly well qualified in the area of pain management. And so it really depends on who the physician is and what skills he or she has in terms of whether or not your pain will be addressed well. Your symptoms may not be well controlled. Palliative care is much more than soft music, hand-holding, and dim lights. There is a real skill set that can take 1 to 2 years post-training in either an area of family medicine, internal medicine, anesthesiology, neurology, what have you. So it's a very detailed form of care that you would be, unfortunately, not be a recipient of. You'll probably not have access to psychosocial experts. I was talking to Dr. Mike Harlows, who's the head of the Winnipeg Regional Health Authority program on palliative care, who's just done a comprehensive review of what services are available in palliative care provincially. If you look in northern Manitoba, so 100 to 150,000 people, there's a half-time coordinator and 0 physicians designated with expertise in palliative care. The chances are that you'll die in an institutional setting, as do 75% of Canadians. You're not likely to have the degree of home supports that are going to be required, so your family is likely going to be in a state of exhaustion, and you yourself might feel yourself a burden to your loved ones. And you certainly won't have the option of entering a specialty facility that is designed and geared to manage your end-of-life concerns. So why is that relevant? Well, it's relevant because physician-assisted suicide is very much driven by things that make people lose the wish to go on living. Now, the truth is, again, if we look in this room, 1 in 6 of you, or about 50 people in this room, would talk about physician-assisted suicide with their families if it was available. And this is taking data directly from the Oregon experience. Of those 50 people, there are about 6 of you, or 1 in 50, so 6 people in this room would take the discussion to their family physician. If we were now looking at a room of about 1,000, in Oregon, about 10 people out of every 1,000 would ask for a prescription. They'd actually go to their doc and have this conversation. The physician would do an evaluation, and 2 out of those 1,000 approximately would receive a prescription. And finally, 1 person out of this group of 1,000 would actually receive a prescription and would overdose and die as a result of that. So we're here discussing today this issue of right to die, and as it's been pointed out, we have a genetically programmed obligation to die. But we're discussing this idea of right to die, which would create a policy of euthanasia in this country when we don't even have a national palliative care strategy. And by the way, the statistics that I've given you about accessibility to palliative care are even worse if we start talking about specific populations like dying children, First Nations, Métis, Inuit, or people living in personal care homes. So the other reason, though, that this discussion is relevant is, again, we really need to look at what drives the wish to no longer be alive. Pain, depression, abandonment, fear of being a burden to others, loss of autonomy, dependency, and if you don't have good care, you're much likely to find yourself in that state of mind. This is taken from a study that we did. This is a woman with end-stage colorectal cancer. She comes into our program with very poor will to live in yellow, which immediately improves upon her coming into palliative care. And concurrent with that, you see are her reported levels of pain. And you can see that when she comes into palliative care, her pain comes down substantively, and that there's this incredible intimacy or tango between will to live and the experience of pain near end of life. So this is what the wish to continue living looks like. This is the degree to which it can fluctuate, and it can fluctuate in response to very specific things. Now, as has been said, palliative care is not a panacea. It's hubris to think that we can deal with all kinds of suffering, because there are some sources of suffering that really are intractable and will linger with us for the rest of our lives. But if you think about this whole issue of suffering, and again going back to the Oregon legislation, suffering is really not on the radar of people who are making that legislation and who are administering that legislation. The criteria: less than 6-month life expectancy. You need to ensure that people are competent, but you don't need to ask them about their suffering. I mean, it is just absolutely not on the radar. There's no obligation to inquire about whether they're suffering. You need to rule out coercion, but there's no obligation that you must see their families. In fact, patients can refuse to have their families seen, and in fact, 20% of patients who actually die in Oregon because of assisted suicide don't inform their families. You need to make sure your patient knows of all of their options. Only about 12% are actually referred for palliative care, and yet we know in 46% of instances when a palliative care initiative is taken that those patients will change their mind. You need to rule out depression. Nobody is referring people to psychiatrists. Less than 3%, some data that I looked at in Washington State, no one was referred for psychiatric consultation. What does this have to do with dignity? And very often we talk about the right to die as the right to die with dignity. It's because, people like me and others in the world study what it means to die with dignity, and dying with dignity means dying with good pain control, providing choices, informing people what to expect, making sure that the tone of care, that people feel looked after and supported and feel compassion. This slide is meant to depict metaphorically how patients hope they're perceived. When you look into the eye of your healthcare provider, you're hoping not to be seen just as the illness you have, but in the totality of who you are as an individual or human being. My last slide, when some of my work on dignity was first being published, the then head of the Hemlock Society wrote the following: "Still, if most individuals with a terminal illness were treated this way," referring to with dignity, "the incentive to end their lives would be greatly reduced." So I look forward to your questions and the conversation we're about to have.
Thank you. Thank you, Harvey. So we now, as Harvey indicated, we come to the question and answer portion of the evening. I mentioned at the beginning that we're working with CBC to help us bring this visionary conversation to a larger audience and to continue the conversation beyond this evening. So before looking to the audience in the room for a question, I'll ask Terry McLeod if he has a question from the social media followers.
Well, I have a kind of double-headed question. One is, what will keep the larger society from killing people for their own good? And who should decide for those who are unable to articulate their wishes?
I don't think that's directed necessarily at any particular person.
No,
Who would
I
like
think
to-
that all of them
Yeah.
certainly have perspectives that might be useful to hear on this.
Paul, would you like to start?
See, am I on?
You are.
The purpose of any legislation is to see to it that it's a request that's made by somebody who's competent to make that request. I don't write legislation or regulations, but that will certainly be critical. However, those regulations won't be written until there is an initiative to do something. They'll be written then.
Okay, well, to address the first question, I guess, and probably to reiterate a bit of what you said, is that the legislation, on the one hand, basically puts safeguards in place, right? So you say the person is competent, their request is voluntary, and so on and so forth. And then they're seen by different consulting physicians. They confirm the diagnosis, the prognosis. They make sure that the information has been given as to the choices available. So that's the one side. The flip side is that that a lot of it is really dependent on how we articulate what it is we're trying to achieve, right? So if we articulate what we're trying to achieve is compassion for people who are at the end of life, then we can construct laws around that to stabilize that and keep it from moving elsewhere outside of end of life, for example. But if we articulate it as autonomy, well, then we can't keep it in the end of life scenario. We can't even keep it in the medical scenario. We just keep it in the autonomy scenario, and so on and so forth. So there's a big piece around, and this all relates to slippery slope theory, but it's really about identifying what is it we're trying to achieve and what is it we're trying to avoid. And if you look at all the legislation in place, they're all trying to, some of them are quite similar, but they're actually trying to accomplish different things depending on the culture. So what we see, even though we have Netherlands and Belgium almost having the identical legislation, we're seeing now through little media reports coming out of Belgium that Belgium seems to be expanding and going into the area where there's arguments being made. Well, this person's unconscious, for example, they're dying anyway, and we should be able to end their life because that actually improves their death. And we've just seen that come out of Belgium in the last couple of weeks, and then we have to ask the question, well, why is that happening in Belgium and not in Netherlands when, for all intents and purposes, this legislation looks identical? It's an important question. To answer the second question, well, who will decide for people who can't speak for themselves? Well, some of this legislation in place in Netherlands, Belgium, and in Luxembourg allow advance directives to be put in place so that you can actually, in advance, when you're competent, say, if this happens to me, then I want you to end my life. So the suffering piece doesn't necessarily have to temporarily or coincide with when the death event happens. So that's something else to keep in mind.
So as not to be redundant, let me point out just maybe a couple of other issues, and that is that because this is physician-assisted suicide, the issue of who decides also implicates the physician. So the patient may decide that the time is now, but because the physician is implicated in that decision, the physician, him or herself, has to decide that the time now is right. Well, what do we know about making those sorts of decisions? Well, first of all, we know, and Dr. Keith Wilson and myself did a national study in which we asked patients about their attitudes and outlooks about assisted suicide. And indeed, we did find a very small portion of patients, it was about 5 or 6%, who said they would be interested in physician-assisted suicide if it were available. But the more interesting and telling thing is that in 10% of instances in a group of 379 patients, we identified patients who said they would have wanted physician-assisted suicide or euthanasia during the course of their terminal illness, but they no longer want it now. So that's one thing. The second thing about implicating the issue of the physician and his or her involvement is around hopelessness. People who request assisted suicide oftentimes feel a loss of hope. Well, the truth is that physicians have to be complicit in that hopelessness and themselves feel that there is no longer any hope. And by being complicit in that hopelessness, there can actually be this kind of illusion that we are both doing something that is positive and that is helpful, and we seem to be moving towards a solution that is going to eliminate both you and I feeling hopeless. The last thing is we have to look at the characteristics of the physician who's implicated in this. And there have been some lovely studies that have been done that have looked at, well, who are the sorts of physicians who would actually decide that the time is now? And what the studies indicate is the physicians who are most likely to acquiesce to a request are those who are younger, less experienced, least amount of experience in dealing with patients who are terminally ill. And also on this particular study that was published by Russ Portnoy, who's a world-leading authority on cancer pain, these physicians also scored lower on their empathy scores. So again, when we ask who's to decide, we really need to look at the fact that it's both a patient and a clinician, and there are dire implications when we implicate the clinician.
Thank you. So we'll take a question here. So please raise your hand to indicate you have questions when there's a gap.
To all the panel, and I really appreciated the clarity of your presentations. But all three of you repeatedly refer to examples of terminally ill patients and palliative care. But I think the specter that haunts people who are in the 65-year-old generation, the Zoomers or Boomers or however you want to call them, is the specter not of terminal cancer or terminal diagnosis, but rather dementia and Alzheimer's. And people who get that are not in a position to choose that unless they make a living will of some kind. I was just reading an article in the latest New Yorker by Michael Kinsley, who was diagnosed at age 46 with Parkinson's 20 years ago, and is now saying that, you know, in all likelihood, he will probably die of something other than Parkinson's, and people that have Alzheimer's will probably die of cancer or stroke or something like that, and that is what will put them out of their suffering, or their family out of their suffering. So I'm wondering if you have any studies that address physician-assisted suicide, or theoretical or practical, in the care of patients who are not at the end of life, but who are in the midst of suffering.
Harvey?
Yeah, or go ahead, Harvey.
Why don't you start?
Well, again, a good question. I suppose the most experience comes not out of Oregon or Washington State, where again the stipulation is around having a terminal illness, less than 6-month life expectancy. But if you look at Holland, if you look at Belgium, there the law is really defined around issues of suffering, intractable or interminable suffering. But it starts to show you what the issues are when you try and draw a tight circle around autonomy. So if we say that autonomy is the thing that is going to drive practice, then where do you draw the line? And what is being found in Belgium and Holland, although the legislation initially looked at this being specifically for people who have a limited life expectancy, the slippery slope has been that the application of euthanasia-assisted suicide has become increasingly broad. So now people who may have a very long life expectation, people who are suffering from depression, a case of a woman who felt that she had intractable, overwhelming grief and couldn't go on living in the face of this kind of loss. So it makes the issue of autonomy a difficult one to argue because it's very difficult to put really good defined boundaries around it.
Mary?
Yeah, so I guess just to add a bit to that, the legislation that's available or that's in place in places like Belgium, Netherlands, and I believe also Luxembourg, because they all more or less look the same, as I've already said, allows suffering not to necessarily, suffering can be physical or psychological, but the other piece of it is that it can be anticipatory. So you may have this diagnosis that things that you're going to have dementia and it's going to get worse and so on and so forth. So you can actually avail yourself of euthanasia for anticipatory suffering. So I don't know if that helps with
I also understand that in Belgium, they're now looking at legislation, expanding criteria, so being greater than 70 years of age and experiencing quote-unquote tiredness of life makes you eligible.
Yeah, and it sounds kind of funny, but I think that's been going on in Belgium, and I guess as well as Netherlands. Now, Netherlands is very clear up to now, like presently, that they want to connect the suffering with some kind of medical condition. But as you get into your older ages, you have a lot of different things going on. So it can be the combined effect of your medical conditions, none of which would necessarily be terminal, but would give you this sense of suffering. And that can also be construed as a form of tired of life or tired of having to deal with taking this pill and that pill and so on and so forth. And Belgium certainly is in the same situation where tired of life is becoming, because Belgium is so much more connected to the concept of autonomy in terms of how that law came into place than Netherlands, that tired of life is a legitimate reason for euthanasia. And another thing to keep in mind is those three jurisdictions have euthanasia and assisted suicide available, but euthanasia is the preferred mode of delivery because it's much more, they consider it to be much more controlled and more humane.
Paul, do you have anything to add? Up here, Chris?
Question to Dr. Sharif and the two others as well, if they care to. But could you comment on the definition of euthanasia versus physician-assisted suicide, and comment on your views of the pros, cons, implications of each?
Okay. That was actually the slide I skipped. So it is actually there. If you just flip, it's probably the second slide there. I don't know, I don't have the, not that it's going to help a lot, but it's there. Oh, we're at the end of the show. We get to see Harvey's, there we go. Okay, so assisted suicide is basically assistance with suicide. So that can be information or means whereby somebody will help you with finding the information that you need to end your life or provide you with the means. It's called assisted suicide and not physician-assisted suicide because it doesn't necessarily have to involve a physician. So this might be, and I'm just going to be blunt here, using, for example, the example of getting a gun for somebody or giving them the helium kit for suffocation, or even in one Canadian case was setting up a device in a closet for somebody's uncle to kill themselves with. So that's assisted suicide. The main thing with the assisted suicide piece is that the death event is brought about by the individual. With physician-assisted suicide, it's the physician that assists. The physician provides the information or the means. The means is usually a narcotic, okay, a lethal narcotic, so they would write the prescription and also give information as to how to take that, right? So but the main thing is that the individual, so that's called physician-assisted suicide or physician-assisted death, which is the preferred terminology in the States. So that the main thing there again is that it's self-administered. The drug is self-administered, okay? Now, euthanasia, though, is a lethal injection that is actually given by the doctor or the clinician to the patient. In all of these definitions could all be described as assisted death. So you could have assisted suicide, physician-assisted suicide, and euthanasia all being described as assisted death. And all of these in particular would presume the voluntariness and the competence of the individual who's making the choice to either have assisted suicide or euthanasia. The pros and cons, it's a big question, but what I will say is that in jurisdictions that have both euthanasia and assisted suicide available, people prefer euthanasia. They prefer euthanasia. So the numbers are higher. Okay, where there's only assisted suicide or physician-assisted suicide available, the numbers are lower. People aren't as comfortable doing that. So I'll leave it there.
I just want to comment on this lady's mention about dementia, because my mom actually had dementia. At the same time, my father was also ill too with kidney failure. Now, my dad decided that after a long process going to dialysis, he wanted to end his life. And that was discussed with my sister because she was the caregiver. So there was no court intervention. The family didn't look at alternative means like kidney transplant or whatever. We just took the will of my dad to let him die. And it turned out that when he died, he actually had a strong heart. So they said, he's got a strong heart, even though he wants to die, he's got poison in the body. It didn't happen. In the case of my mother with dementia, she actually waited until my sister left to go on a holiday. And I don't know, we didn't get into the detailed stuff about understanding dementia, but my sister went on a holiday, and they called her on her vacation, said, your mother has died. I'm kind of wondering if in that case, my mom didn't want to live continuously. She lived to 86. We thought she'd make 100 because all her relatives made 99 to 100 years old. But in the case of my father, he just made a will to die. And he said, no more dialysis, because if we don't do it, you're going to die. And that's what he chose. And us kids, we just accepted that with my dad.
Thanks for that. Any reaction?
First of all, thank you for sharing that story. I think it's very meaningful for all of us to hear about you and your family experiences. The choice that it's hard to know the timing of your mother's death and how we can understand that or explain that, whether somehow by your sister being away, she felt that she could somehow let go of will to live, or what initiated that timing is hard to know. But your father's death is one that is interesting, and that is that he chose to forgo any further treatment, right? And certainly in Canadian law and in practice of medicine, the idea of our having the right to no longer want life-sustaining treatment, so the discontinuation of it or not electing to receive life-sustaining treatment is very much a choice that all of us have. I think it's important to point that out because it differentiates this from physician-assisted suicide or euthanasia. No physician was implicated in the death of your father. Your father made a very competent decision that he no longer wanted treatment, and that is certainly something that all of us have the right to do. It also harkens back to the question about dementia, and it really points out the fact that making our wishes known, having an advance directive, naming a healthcare proxy, telling people what our outlook is on end of life and what choices that we would want to make, and we do have choices that are available to us, is of such extreme importance.
Thank you. Up here, Chris?
So it appears that this conversation centers, perhaps doesn't center, but is shaped by this idea of human rights. I may be wrong about that, but I think it has to do with human rights, and there are many human rights. And if I'm right about that, if this is about rights, I don't mean to be glib when I say this, but it's the best way I can put it. Whose life is it anyways? So that might be my question, is whose life is it anyways?
Anyone want to reflect on that? Comment on that? Paul?
It seems to me that everybody up here has been saying that it's the patient's request that would determine their life being brought to an end. That's whose life it is.
True enough, Paul. But at the same time, what we're also saying is that if we were to change Canadian legislation, if we were to change policy, if we were to change sort of the fundamental nature of medicine in many ways, then it also implicates the actions of healthcare providers. And that's an important thing to add to the dialogue of whose life anyways. It is the patient's life, but you are now implicating the physician in taking a very active role in making that stance. And we know that, we've done studies that have looked at why do people want to die. Well, we know that in 80% of instances, they're in pain of moderate severity or greater. We know that about 70% of them will be suffering from syndromal depression. We know from other studies of even interest in assisted suicide that a person who is saying, this is my life, this is what I want today, and that is the end, after the fact may change their mind. So yes, it is each of our lives, so long as we're making decisions what we do with ourselves and for ourselves, but when we implicate a healthcare provider, the dialogue changes substantively.
Could I just ask,
Yep.
perhaps I think both Paul and Harvey commented on what to me is an interesting, I think, gloss on that answer. Both of you, I think, suggested, or at least it seems a suggestion to me, that there is a collective responsibility as well. Because if we collectively decide to, say, tax ourselves to provide a palliative care system, we can change not only the dynamic for the patient, we can change and for the physician, but we can change the societal response. At least it seems to me that's what some of the data that you were quoting would suggest. So it's not just, while it may be the individual's life, and it may in the end be a transaction between a physician and a patient, the context is determined by decisions that we'll make collectively. Is that fair? Paul?
Well, yes, but here we are talking about an idealized palliative care system, and we're setting that and using as examples extremely isolated populations, that's thinly spread populations with minimal resources available there. I'm reminded of once giving a team presentation in Interlake about coordinating the multiple disciplines who can be helpful in providing hospice and palliative care, only to find that the whole Interlake area had one social worker responsible for every provincially covered social service, whether it was mental health or mother and child or, well, I don't know what all they did, but it could, if we could indeed dedicate all our resources to providing superb palliative care everywhere in the country, but it would use up all our resources, just like every other idealized fulfillment that we would have, whether it's in education or transportation or whatever. There are limits.
Yeah, I'm not. I certainly agree that there are limits. I'm just saying it's more than just two individuals, right, who are involved. We establish a context for those decisions. Other interventions? Over here?
Oh, thank you. It's been terrifically interesting to hear all of you, and I've learned a lot, so thank you very much. My question is, like Mary, I teach in the law school, and I am always interested in, when we talk about these issues with our students, I think it was, somebody said that it was around 50% of people favor assisted suicide. I find that the number is very high among my students, or that are very, comfortable with that idea. And I think that often when I introduce some of the other, the arguments, the various arguments on different sides of that issue, which I think you've done a really nice job of, it becomes more complicated, but they still seem pretty, committed to that idea. And I think we often don't think enough about how our society values and thinks about people with disabilities, how we think about, what it means to have a life worth living and all of that. So I think that's terrifically important in this discussion. I do want to, though, pick up on the idea of the court challenge and it being about autonomy, or potentially about autonomy. I think, Mary, you know more about this than I do, but my recollection of the case is that it's not really being argued on the basis of autonomy so much as security of the person, and the idea that a security of the person is threatened when they are grievously and irremediably ill and they don't have the ability to make that it's an arbitrary choice this is the argument that's being made, I think. It's an arbitrary choice to say that you can't get assisted in a suicide to end your suffering, right? And that a person who doesn't have a disability or who is able to do that can do that on their own, and we don't criminalize that, for example. And one of the big pieces of evidence I understand is this idea, and this is maybe where Dr. Chochinov might be able to assist too, is this idea that that in palliative care there is this idea of terminal sedation now, and that my sense in the evidence that was quite persuasive that we withdraw, and you can help me with this, but it's something about administering a lethal dose of sedation as well as withdrawing nutrition and hydration, and that is seen in law as an act of ending life. And am I wrong about that? Because I thought that was quite significant in the decision as I read it.
So can we start with the first part, Mary, and then go to Harvey?
Okay, so in the Carter case, there's a bunch of different arguments. There's the Section 7 arguments, which are about liberty and security. There's the Section 15 argument, which is the equality argument. So you've got, what you're talking about there is a combination between the security argument and the equality argument. And then there was also a very interesting argument around the right to life, saying that. So I'll deal with each one of those if there's time. I'm not sure what the time is, but I'll try to deal with them. So the liberty and security arguments are very similar, okay? So you have to really read the Rodriguez case as well as the Carter case to really get a sense of how they differ. But basically you've got your right to liberty, and the argument there is that you should be free from unwarranted or undesirable interference by the government in personal decision making. The security one is about the bodily integrity, okay? And that you should have choice around your bodily integrity. Now this combines though with that Section 15 argument, the equality argument, which says, well, people who are able-bodied can commit suicide and they aren't penalized by the law. But I who have a disability, and if I'm in this progressive disease, I start to lose my opportunity to be able to take my own life, and therefore this is an unequal treatment, okay? There's two, so that's basically what that argument is about. And that Section 15 argument was accepted to a certain extent in Rodriguez as well, right? So what am I trying to say? Deborah, what are you asking about that in particular?
I thought it was that arbitrariness argument. Isn't that the principle of fundamental justice that they should have?
Yeah, well, they said it was arbitrary to allow this for these people who are able-bodied and not to allow it for people with disability. But it's still, that's the Section 15. But the Section 7 is not about the arbitrariness, although there's overlap in those arguments in the judgment. Okay. But it's definitely the concept of autonomy through the liberty and security, and then the equality argument through Section 15. But the arbitrariness does factor in, and again, as I've already said, and I'll just say it again, that they overlap, right? But the issue about assisted death really is not about equality rights, right? It's really about how do you respond to somebody's suffering, ultimately, and as the gentleman pointed out, which I didn't think up there is a glib comment at all, it's whose life is it? And it is really about interpreting these concepts of liberty and security in the context of autonomy. What was the other piece there?
Sedation.
The terminal sedation, yeah, so there's some clarifications required there for sure, but I'll let Harvey do that.
Well, I'm not going to comment on that first, and I'm going to ask my colleague to step in on in responding. But the issue of overwhelming support, and you mentioned that if you look at surveys, that a very large majority of Canadians would support physician-assisted suicide, euthanasia. The death with dignity in Oregon came in on ballot with a good majority of Oregonians saying that this was appropriate policy. When you look at a group of patients who are near end of life, as we have in our studies, only about 10%, so from 60 to 70% in the general public, about 10% of people say they have a desire to die. When you then look, again, and it's a hypothetical scenario, if you had access to euthanasia, physician-assisted suicide, how many dying patients would actually say they would want it? About 5% in hypothetical circumstances. What about in a place where it actually is available? Less than 0.5%. 1 in 1,000 in Oregon actually avail themselves of assisted suicide. So when I look at that, what does it mean? I think it means that when we're healthy and well, we're very poor at being able to predict and anticipate what our true wishes would be in circumstances when we're no longer healthy and no longer well. And now I'd like to ask if Dr. Mike Harlows, who is the medical director of the Winnipeg Regional Health Authority, could comment on the issue of palliative sedation.
Thanks very much. So just to clarify, there are very rigorous guidelines and standards around palliative sedation, and the Canadian Society of Palliative Care Physicians has recently published those for the Canadian context. But palliative sedation is the reduction of consciousness or alertness in someone to relieve refractory suffering when death is imminent. And the key there is that the death due to the underlying illness has to be proximate enough that they will die from that and not from the results of sedation. The doses that are used are proportionate and measured only to reduce consciousness, not to compromise physiology, not to reduce breathing. Sometimes I'll use the metaphor of if you've fallen out of a plane, you have a fatal condition, loss of altitude. And if I sedate you, and it takes any of us, if we were sedated this moment, it would take about 10 days to die. That's what we saw when we withdraw food and fluids with Terry Schiavo in that situation, when we see people present to emergency with a massive stroke and the family says they wouldn't want anything but comfort. It's about 7, 10, 14 days to die. If someone is going to die in 6 months, no palliative care physician would sedate them or provide palliative sedation. If they're going to die in the next 3 or 4 days or a week or perhaps a couple of weeks and you've done everything you can, and that's part of the guidelines is to do whatever you can to try and address the suffering, then most physicians would sedate. What's quite interesting is that, again, it's measured, proportionate, and monitored. And very often, even with fairly light sedation, people will say, okay, this is good enough. You've taken the edge off life, and that's actually good enough. I can wake up in the afternoon and talk to my kids, and then I can get some more. But it is most certainly not the administration of a lethal dose, and it's done with the attention to the proximity of death. So.
Thank you. That's very helpful. Could another intervention at the back?
Could I just
Sorry,
jump in?
Mary?
I just wanted to add one more thing with respect to the support for assisted suicide. And the only comment I'll make for that is, yes, the polls are demonstrating support for assisted suicide. There's no question. But I guess the question I have is, okay, how are we defining it? Because if we're talking about assisted suicide based on those definitions, we're talking about self-administration of a lethal dose, right? What's happening through the Carter case and what's happening in the legislation, whether it's Quebec or you're talking about the Stephen Fletcher bill, is not assisted suicide, it's euthanasia and assisted suicide. So we need to really understand what the polls are asking and understand also the definitions and what is actually being formulated in the legislatures and in the court.
Thanks.
Thank you very much for a fascinating discussion. I wanted to relate to the point that both Dr. Heneleff and Harvey Chachanoff raised about the ambivalence in some ways of the physician's role, particularly where you have a dual standard like they have in the Netherlands. About 20 years ago, we brought people from the Remling Commission, including Van Delden, here to speak at the medical and law school. And that was one of the sticking points in terms of the Dutch protocols of the physician's role, not in incompetent administration of medication, but the other roles that were being asked in terms of validity, assessment of pain and suffering, assessment of competency related to autonomy, related to some of those other issues. and in a study that Dr. Chachanoff and Jim Dirksen and some people here have been involved in, we did some work with medical students, with residents, with practitioners working in palliative care and intensive care medicine. And we looked at the 9 or 10 training opportunities that doctors as undergraduates had in end-of-life ethics and palliative care medicine. And the areas that students were most ambivalent about and residents were most ambivalent about was when it had to deal with either the issue of the quality and sustainability of the life left to the person, to the efficacy of interventions that might occur, and to their own feelings about the person's disability or the things that they were living and dying with. And there was great diversity among both the medical students who were being taught, but also the people mentoring them, including ethicists, working clinicians, and people with disability and chronic illnesses. And one of the real sticking points in the legislation has to do with what we're asking physicians to do in terms of decisions about the quality of another person's life, the validity of their suffering experience at one point in time. And it's an area where we need to know much more about it, because the physician as an agent, as a gatekeeper in one or other ways, is profoundly understood.
Thank you. Harvey?
So this role of the physician that you raise, and the issue of difficulties in being able to evaluate the suffering of another, the way that they've dealt with that in the Oregon legislation, as I said before, is by simply saying if you have a prognosis of less than 6 months to live, we don't need to ask you anything at all about your suffering. If I can just read, there's just a short paragraph here describing an actual case that was reported by the Compassion for Dying. And this is a recording from a patient who actually availed herself of a physician-assisted suicide. This was a woman named Barbara. She had advanced breast cancer. She and her husband had decided that she wanted to seek out physician-assisted suicide in Oregon. They went to their family physician, who thought that this wasn't appropriate, decided that they would go to a second physician, who decided that she was depressed and wouldn't give her medication. So they then got frustrated. They went to the Compassion for Dying. One of the leaders of that, Barbara Coombs-Lee, said, you know, I'll shop for a physician till I get the opinion that I need or want. So she went to this third physician, and this is a recording that took place between this patient and the physician. The patient said, I've seen people suffer. They give them artificial feeding and stuff, which is really not doing anything for them in the long run. And then the doctor responds by saying, can you explain how you feel about dying in a few days? Now, anybody here who knows palliative care knows that there's an incredible opportunity that's just been missed because the physician did not say, well, wait a minute. No one is saying that you have to have artificial feeding. No one is saying that that is the direction that you would have to go. But the doctor carries on to now point out what the options are and says, well, there is, of course, all sorts of hospice support that is available to you. There is, of course, chemotherapy that's available that may or may not have any effect, not in curing your cancer, but perhaps in lengthening your life to some extent. And there's also available a hormone which you were offered before by the oncologist, tamoxifen, which is not really chemotherapy, but would have some possibility of slowing down or stopping the course of the disease for some period of time. And the patient says, yes, I don't want to take that. And the doctor responds by saying, all right, okay, that's pretty much what we need to understand. She then is given a lethal prescription and she dies within 15 days of having met this doctor. So that's how the issue of evaluating suffering works. It's not on the radar.
Okay, folks, we're getting close to the end, so my colleagues with the microphones. That was my morbid vice president. So we'll take the question up here. If there's time, we'll take another one here in the middle. If there's still time, we'll take another one from Terry. I don't think there will be that much time, so let's go up here.
Yeah, there's quite a bit of, incidentally, I haven't decided in my mind yet whether I favor physician-assisted suicide or euthanasia, but I've noticed there's been a lot of discussion. They're afraid that the patient might be pressured into checking out early. I'm concerned from the other aspect, if there is to be a right to die, it has to be very, very clear that the patient unconditionally wants to die, that he or she couldn't use this as a means of emotionally blackmailing or extorting relatives or others. I mean, has anybody thought of that? You know, somebody saying, okay, if you take me out of this hospital and keep me at home, I'll live. I mean, that can't be allowed. I respect, and I take this beyond even the right to die situation in terminal illness. Even the matters of hunger strikes in prisons or for political purposes. If a person wants to die on their own, well, it's unfortunate, but it's their right. But if they do it as a form of extortion, I think the law should be entitled to set in, if need be, to force feed somebody. I was just wondering what your views on those aspects of it are.
Thanks for that observation. Any response? Paul?
Well, I think of something I wrote long ago. It was along the same line. Patients who happen to be dying aren't necessarily saints. They can be just as manipulative on their deathbed or on their sick bed as they were at any time during their life. It's not common, but it happens.
Chris?
Wondering how it is that so far we see, growing up, I was familiar with the term euthanasia for animals. And I find it interesting that so far we have euthanasia for animals, and an animal can be suffering to the point where we have decided that it's probably best that it would die. And we can euthanize an animal, but we haven't yet afforded that right to someone to take that decision into their own hands and to have the autonomy to decide, this has gone far enough, I can't live like this anymore. I was wondering particularly if Mary had any comments on that.
I was wondering if someone was going to ask that question, because I like animals, right? But animals are animals and humans are humans. And I think that is a distinction that we can make by virtue of us being human. And I don't know, Harvey, did you want to follow that?
No, I like that. Animals are animals, people are people. And do we really want to start treating people as we would animals? So, you know, when animals get inconvenient to look after, you know, if they're becoming incontinent, if the bills are running up, we take a particular strategy, which is to eliminate their suffering. We eliminate the animal. We treat humans very differently because they are human, and I don't think that we want to start kind of lowering the threshold of how we treat human beings because we have a particular way of ending the lives of dogs and cats.
Here?
Yeah, I guess I just have a couple of comments. One is that I'm wondering about this notion of the directness of the doctor's connection. It seems to me that we're not going to be compelling any particular doctor to have to participate in something like this if we do adopt a form of any kind of assisted death. It's not going to be a question any more than it is with respect to any other medical decision that is made. There are doctors who do not want to withdraw feeding. Then the person has the right to speak to another doctor and can eventually find one who will agree one way or the other. And it seems to me that to suggest that because it's asking doctors something, that becomes a reason why we should not be considering the issue of autonomy with the same weight. It's not an equality of having autonomy over myself and you as a physician having to prescribe a medication. My father was a physician. I know what his commitments were for not doing any harm. But he also believed that when a person had had enough, it wasn't available to him to do any kind of euthanasia. But he believed that that person had the right to make the decision about how far they would go. And if euthanasia had been available, he would have been prepared to participate in it. So I think, but he would never have expected that all his colleagues would have to do so. So I think we have to separate The fact that physicians might have to be involved in it at one stage against the issue that this is not going to be a compelling of physicians. I also have difficulty with people commenting about, well, we never know what we're going to feel in the future. And if we're going to have autonomy, and I would have questions about how we determine that autonomy, but if we understand at the time when we make the decision, if we understand the consequences, and we know that we might change our mind, and we yet still decide that we want to make that choice, then whose right is it to say to me, no, because I might change my mind, I have to continue to live? It seems to me that it's my right to make a decision over whether I'm going to continue to exist or not. And as long as I know what that means, and it means the end of my existence, or my transfer to another level, or whatever it is, then it's nobody else's decision to suggest that whatever may come is more important than what is now, or may have been, in my mother's case, a 45-year commitment to choosing her time of death.
Comment? You want to comment? Yeah. No? Mary?
What I would say is this in response. Absolutely, right? These are very personal decisions, right? And whose life is it anyways? You've heard, right? And that's an important thing to think about, right? So nobody is stopping anybody from walking in front of a bus or doing these kinds of things, right? What this is some kind of agency that we're asking for that involves another human being to end the life of the person who wants to die. Nobody's going to compel somebody to do that. There's conscientious objection as well, right? But there's a negotiation that happens there between patient and physician. And we have to think very carefully about that negotiation because it's not an equal relationship, right? There are people that support assisted suicide and physicians that support assisted suicide for terminal illness, but they don't necessarily support euthanasia for terminal illness because of the power differential that exists there. So that's an important piece. The other thing too is the Netherlands law developed through physician participation in these particular activities. And it was a negotiation between the physicians and the patients, and the physicians coming to this conflict where they had to try to reduce suffering, right, and protect life. And they get to this threshold where when they're trying to treat, it's actually causing more harm. And that's the threshold, that was the conflict that actually generated the Netherlands legislation, okay? And that acts as a constraint and contains it within a medical realm for Netherlands. Belgium takes that same legislation, attaches autonomy to it, plops it into Belgium. Belgian doctors are saying, okay, what is it you're asking us to do? And this is another important piece, is that medical associations, by and large, are very concerned and don't necessarily want to actually enter into this type of activity. So I think it's the Belgium situation where they attach the same legislation but to the concept of autonomy. And then you have doctors wondering, okay, what does this mean for me, right? How do we approach this? Is this being imposed upon us, right? So there's a whole negotiation and an agency that's occurring here. It's not about just somebody ending their own life. It's actually this relationship where you're asking somebody else to do that, and we cannot lose sight of that. And this is where potential abuses can occur. And so we have to listen, we have to think about what it is we're trying to achieve. We have to think about compassion and empathy as much as we have to think about autonomy, and we have to have a Canadian resolution to the issue, not a Dutch resolution, not a Belgian resolution, not a Switzerland resolution, but a Canadian solution.
Thank you for that. I want to thank, I apologize, Terry, I think we're too close to the end to take another question. It's a really good, I think a really good question means a fairly long answer. I want to thank all of you for coming. And in two senses, I see many people in the room who have been regulars for the season, and some of you for the several years that we've been doing these visionary conversations. They have had, they've had an impact that has been very positive, and we really appreciate your continuing presence. And for those of you for whom this was the first time that you've come, we appreciate your interest in tonight's topic and hope that you'll come back for other sessions. And I appreciate the straightforwardness of the conversation tonight, both from the audience and of course from our from our panelists. This is an issue that's close to all of us. I expect we could all tell stories about family members or friends that we've seen suffer, and the possibility of our own suffering or the suffering of those who are close to us haunts us. And so I don't know about you, I've certainly had my own thinking stretched by this evening, and it makes me, again, proud to be associated with this community of scholars, and I want to thank our panelists for the work that they've done for us tonight. And I would like to invite you to visit our Visionary Conversations website at umanitoba.ca/visionary conversations for a new feature this year called After the Conversation. Over the next few days, we'll be uploading articles and studies and links to websites referenced in or related to the conversation tonight. So if you want to pursue that, that would be great. And I would like to invite you to attend an exciting event tomorrow at the Winnipeg Art Gallery, the Distinguished Alumni Awards, which will celebrate 5 of our outstanding alumni and their amazing achievements. For more information, you can visit our website at umanitoba.ca. This is the final Visionary Conversation for the season. Please check the website during the summer for a preview of the coming season, which we will kick off during homecoming. Thank you again, and I look forward to seeing you then.